committee. Apologies for the slightly late start, but obviously it's a horrible morning and some members have had some distance to come and I think the weather's held them up a little bit. Anyway, good morning. Members of the committee present this morning are Councillors Jane Langford, Nick Carter, Owen Jeffrey and Stephanie Stevenson. Stephanie Stevenson is at present a substitute for this committee, but she will be taking over as a full member for Councillor Justin Pemberton, and she is today substituting for Justin Pemberton. Council officers and external partners joining us to advise and support the meeting are Paul Coe, Executive Director, Adult Social Care and Public Health. We haven't got Anne-Marie Dodds. We're not sure whether she's joining us later. Rachel Johnson, Senior Programme Officer, Public Health and Wellbeing. Stephen Bow, our new consultant in Public Health. Have we got Matt Pierce?
Yes.
Matt Pierce, who's on Zoom. Adrian Barker, also on Zoom. Matt Pierce, Director of Public Health. Adrian Barker, Chair of the Mental Health Action Group. And I don't know whether he's there yet. In place of Fiona Warby, Lead Officer for Health Watch West Berkshire. Today we have Jamie Evans. Is he there? Health Watch Area Director. Sorry, I can't see your name, so I'm sort of peering and hoping that you're there, but I think you're all there. And from Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board, Bob ICB. We haven't got Helen there yet. Yes. Is she there? Hello. Oh, yes, she is. Hello. And we have Helen Clark, Deputy Place Director, Berkshire West, and Colin Edwards, Head of Joint Commissioning. Colin is here instead of Dr. Heather Howells, our GP representative. I do appreciate that GPs have a very heavy workload and, you know, it's difficult for them to attend these meetings, but I think and I think other members would agree, it's really important that we have a GP representative here because all these wonderful actions that are being listed in reports, it's down to the GPs and health practitioners to deliver them. And, you know, we'd really like to know how they're getting on with that. But I think, you know, whatever we can do to facilitate the attendance of GPs at these meetings so we can hear straight from them how things are, I think would be very welcome. Maybe they need a bit more notice, not sure. From Berkshire Healthcare NHS Foundation Trust, we've got, and I do appreciate, if I don't pronounce this correctly, I don't know whether he's here yet, Gary Failure Funtulaki, is that correct?
I'm here.
Oh, that's you. Hello.
Yes, that is.
Okay, thank you. Okay, Clinical Director, Community Mental Health Services, Berkshire Healthcare NHS Foundation Trust, and Sue McLaughlin, Clinical Director for Urgent Care Pathway, Trust Lead for Suicide Prevention. Vicky Phoenix is the meeting's also being live streamed via YouTube, and Gordon Oliver is the Zoom host. Before we start proceedings, I'd like to explain for the benefit of members of the public who may be watching that this morning's meeting is being held over Zoom and with councillors present in the council chamber. The meeting's being live streamed on YouTube, so members of the public are able to follow proceedings. And please can I ask everyone participating to make sure they switch on their microphones when invited to speak directly into them and switch them off when they finish speaking, otherwise we get feedback. If we hear the fire alarm this afternoon, we must leave the building immediately via the emergency exit. The assembly point is the Dolphin car park. If the lockdown alarm sounds, we will remain seated and await instructions from officers. We'll adjourn the meeting until such time as it is safe to proceed. Do members have any questions about the way in which this meeting will be conducted before we proceed? I don't think so. Okay. So item one, Vicky, do we have any apologies?
Yes, Chairman. We've received apologies from Councillor Heather Codling, Chair of the Health and Wellbeing Board, from Councillor Patrick Clark and from Councillor Justin Pemberton. Councillor Stephanie Stevenson is here in Councillor Pemberton's place.
Okay. And Councillor Patrick Clark, for anybody, you know, or visitor who doesn't know, is the new portfolio holder for adult social care, which includes public health. Okay, thank you. Right, item two, the minutes. So hopefully everybody's seen the minutes. So the minutes of the meeting held on the 11th of June. Can I have a proposer from the councillors? Thank you, Jane. Jane's proposed. And a seconder? Right, Councillor Carter's seconded. Thank you very much. And then I will sign those. I was just going to draw attention to, on page 4 of the minutes, item 8, when we discussed the annual report on public health. I think it was noted about the concern about obesity in children and in adults. And I think this is something that we've taken on board, and it will note that this is going to be something in our future programme. Okay, thank you. What's the date? 20. Thank you very much. Thank you, everybody. Item 4, do members have any declarations of interest? No. Item 5, Vicky, do we have any petitions?
No petitions have been received, Chairman.
Thank you. Right, item 6, we have a overview of the reports in your pack on mental health, and we have a report from the council's team presented by Rachel Johnson, and she will kick off, and you can see in your pack who else is involved. We also have reports from Bob as well. So Rachel, if you would start by giving us your report overview. Thank you.
Thank you, Chairman. Hi, everyone. My name is Rachel Johnson, and I'm from the public health team, leading on public mental health. The report in the pack gives an overview of public health's role in mental health and wellbeing, and some of the initiatives that have been funded through the public health grant. So just to start off, we know that we all have mental health, and the role of public health is not just to focus on mental ill health, but everyone's mental health and wellbeing. With that in mind, I'd just like to invite you to spend a couple of seconds thinking about how you look after your own mental health. I wouldn't be a public health professional if I didn't throw that one in. We know that it's important to focus on how we can improve our mental health and prevent mental illness. And in public health, we do that by helping people to understand the steps they need in order to maintain good mental health and wellbeing. So in the paper, I focused on 3 levels of prevention, and I was going to briefly mention some examples of primary prevention, some of which you may already have come across, but I thought it'd be helpful for you to know about these, and they would help you in supporting your residents, especially if they are coming to you with any mental health concerns. So for those of you on Zoom, I have distributed some resources to members in the room, but they will be shared in the minutes. So the first one I'd like to draw your attention to is a signposting sheet. It's 2-sided, and it contains all the resources that West Berkshire residents could go to if they're experiencing any mental health symptoms. So if they're struggling with their mental health, it's really important that people get signposted to services as soon as possible in order to prevent deterioration of mental health. So we've themed the sheet into different groups. So there's mental health support groups such as Recovery in Mind, 8 Bells for Mental Health, and Talking Therapies highlighted. There's also information on there on how people can support with keeping active, because that is good for mental wellbeing. We added a new section in last year as a result of some work we did with the Mental Health Action Group around supporting people with money worries, because that can affect mental health. There's some information about people affected by bereavement. And then on the back, there's resources for people who are young people, and then some other national resources. So that's a really good kind of summary of what's available in West Berkshire. We used to have it in a fold-out Z card that some of you, so we used to do it as a Z card, but they are quite expensive to produce, and the information can go out of date quite quickly. So we haven't produced the Z card this year, but that's something we could potentially look at if that was something that House Scrutiny was interested in supporting.
So how often are these updated then? Is that?
So I try to update them yearly, but usually I find out, because I'm in the area, I find out if services have closed or decommissioned or changed, so I can quickly update the leaflet, and it's available on the council website. Owen,
Okay, so the practitioners need to be constantly checking whether they got the up-to-date information, don't they?
yeah, it has got a date on the back when it was last updated. So this says June 2023. And I do know the services are still kind of going. I don't think we've had any updates lately.
I think we were going to do the two presentations first, but if you've got specific ones for this, carry on, Owen. Yeah.
Thanks. Rachel, can I just ask, you're saying the expense, what's the approximate expense of this and what would have been the approximate expense of the Z card?
I think off the top of my head, it was around £2,000 for about 15,000 copies, but I need to go back and check of the Z card.
Sorry, what's the relative costs of the Z card and of this compared?
Oh, this is a lot cheaper because we can get this printed in-house. Whereas the Z card we have to use an external printer, and that's where the costs come in, because it's printed in a certain way that our print room can't produce. So we have to use the Z card company.
Yeah. I mean, the Z card was quite handy. You know, I've still got one stuffed in my pocket somewhere, I think.
Yeah.
But it does you know, the folding out, it sort of deteriorates around the edges. And I think it's the updating that's important, really, isn't it?
Yeah, I know service users did find them useful because they could put them in their purses and their wallets and things. And people like to give them out at events. It was quite easy. People could tuck them away in their bags and stuff. So they are good. But it's like the more you produce, the cheaper it is. But then the more expensive it is as well, because you're producing that many more copies. So if you're not using them, they get wasted.
Also, people who are techie, they can get this stuff on their phones, I suppose, can't they?
Yeah.
Okay.
The next one is I'd like to talk to you about the 5 ways to wellbeing. So if anyone takes notice of public health advice on your 5 a day for fruit and veg, hands up. There's a 5 a day for mental health. So the 5 ways to wellbeing are connect, be active, keep learning, give to others, and take notice. And the leaflet I've handed out gives some kind of tips of what's available in West Berkshire. So for instance, on the West Berkshire directory, there's information about lunch clubs and day centres that people can go to. The volunteer centre also has some volunteering opportunities that provides opportunities for people to connect. And then there's also the befriending service. In terms of Be Active, Public Health lead on running and walking groups that are available around West Berkshire, and they give people opportunity to be active and connect, and people can also even volunteer to become a walk leader themselves. The council also funds a range of leisure centres around the county, around the borough, so people can go to those. Sport in Mind, an organisation that supports people with mental health to get into fitness, is also on there. Keep Learning, there's information about maybe trying a new craft activity at the museum, or maybe exploring Shaw House. And there's also talks at the museum as well, so that's a good way of keeping learning. And there's Newbury College that run a few courses. And then Give to Others. I've spoken about maybe donating some furniture to Newbury Community Furniture Project, or maybe you could sponsor someone who's raising money for charity. And then Take Notice, so maybe you could go for a walk at the Nature Discovery Centre. We know that being mindful and maybe deep breathing is good for your mental health. So these are kind of like the 5 ways to wellbeing, and we promote these quite a lot because they are evidence-based actions that people can do to improve their mental health. And it might be that you could do 2 or 3 at the same time. So for example, yesterday I went for a swim with a friend, so that was being active and connecting, and then I was taking notice when I was doing my lengths, and I was just being mindful. So there's quite an easy thing that you could probably promote to residents as well.
You mentioned 5 ways to mental health in your report, and I was going to ask you what they were.
Yeah.
Because you don't actually say what they are.
No, but there's a hyperlink. So if you click on the hyperlink, then it will take
Oh,
you
was
to
it?
our
Oh,
webpage.
okay. I was
Yeah.
just looking at the.
No, that's okay.
Okay.
There's a web page on the council web page all about the 5 ways to buy it, but wellbeing, and then there's hyperlinks to all the activities.
I mean, of course, there's loads of other. I mean, Babout is a partner of
Yeah.
the council. I mean, they do
Yeah.
a lot of stuff where you can get out into the countryside as well.
Yeah. Yeah.
Anyway,
definitely.
thank you. That's good. Yeah.
And then the next one linked to the 5 ways to wellbeing is wellbeing bags. Some of you might have seen the library promote these. So this is an initiative that Public Health did with Newbury Library. I worked with Jackie Cooper to come up with these. So these are bags that residents can borrow from any of West Berkshire libraries, and they contain information about, they contain contents that are linked to the 5 ways to wellbeing. So it's a bag that people can borrow for 3 weeks free of charge, and they contain lots of different resources. So you can see, for instance, there's the Uno card game that would help people connect with their family. They can do colouring to keep mindful. There's relaxation CDs. There's a recipe book to try new recipes. And what we try to do each year is update the contents of the bag so people can borrow them more than once. So we're looking to refresh the bag contents during South Care Week in November. So that's something that we've been working on. And I think that's quite an initiative approach. Not every area has these bags. So that's just something that we're doing in West Berkshire.
I'm aware that our people on Zoom can't see all these lovely leaflets.
No.
So we're going through a set of leaflets here, which are quite colourful and quite eye-catching. But I'm sure they will be on the council's.
Yeah, they are, and on
website.
our social media as well. And what I was going to go on to next was national campaigns. So we promote all of these resources during Mental Health Awareness Week and World Mental Health Day. And we also produce resources published by the NHS. So we support national mental health campaigns such as Every Mind Matters, and they also produce some little tips on how to improve mental wellbeing as well. So those resources are ahead of you. I just wanted to finish by saying that it's not just public health, but do public health initiatives. As I highlighted in the paper, that there's some other parts of the council that support with mental health. So there's the family hubs, there's the provision of a domestic abuse service that support people going through that. There's a substance misuse service that's commissioned, and we know that some people with drug and alcohol issues have mental health problems, and so that's another way the council supports. And then obviously the leisure centres, the museum, and all the green space that's available in West Berkshire. So I think I'll finish there, but hopefully I've given you an overview of public health's role in mental health.
Thank you very, very much, Rachel. It's an interesting report. And as regards these leaflets, I think we'll hear the NHS report before we ask questions, because there might be sort of overlaps and one might want to comment on the other. I'm just wondering, obviously one hopes that these are accessible and people use them. Are we sending them out to parish councils? Are we making sure all our councillors are aware of these, so they can, in their activities, sort of, so at least be made possibly aware on with an email about what's available. Are they left in reception? Are they available in reception?
I think there was a move not to have leaflets in reception, but I can definitely send an email to all councillors with the attachments on. That's a really good idea.
I'm all for leaflets in reception, actually. I think you often see people hanging around there waiting for their appointments. So, and you look around looking for something to read. I know you've got the screen, which has Stephanie, a star of the show at the moment. I think whenever I come in, she seems to be on it. But I think, I don't know. I think maybe Nick wants to comment on this. I won't carry on too long here because we need to hear the other report, but yes.
Yeah, just a quick one. Yeah, so where do you use these? Where do you hand these out? Do you hand them out at sort of when you're out and about somewhere? Is that mainly what they're used for?
Yes, they are taken to events where public health have a presence, and then we also share them through partners so they can share with their service users. So we work closely with the range of different organisations, and so they have the materials as well. And then they're on our social media pages and the council website. And then occasionally we have updates in the resident newsletter as well.
Yeah, sorry. And the other thing was I looked and noticed that because I'm in one of the villages and I felt that the leaflet focused a bit on Newbury. But then having said that, when I looked up, you gave the example of the lunch club and I had a quick look on the directory and all our lunch club is on there. So, yeah, I think it's obviously a lot of the activities are West Berkshire general. But I was just a bit worried because it lists specific Newbury venues, but yeah, I can understand why you have done, but yeah.
Yeah, we could maybe tailor them to local areas if that would be useful. But yeah, it's quite generic at the moment.
I think that's an important point, Nick, actually, making sure we think about our rural areas and not just focus on the big towns. I think that's something that's evident in other reports as well. Yes, Owen? Yeah.
You just made the comment that apparently we have a policy of not having leaflets in the reception area. Is that correct?
Well, I don't know. We can check on that and maybe revisit it, okay?
I think by revisit, can we change the policy to one where we do have leaflets?
It's up to us, Owen, so we can revisit it, can't we? I think we can ask about it. Is that what you're asking?
Yes.
Okay. Is that okay? You're looking puzzled.
Well, where has an instruction come from that says we can't have leaflets in reception? I don't think so.
Just thinking off the top of my head, I imagine this possibly came in during COVID or something related to that. It could well be because people were just sort of getting rid of anything that could cross infection. And then things just stay and nobody goes back and looks at them. So we can go back and consider why we've got that policy and whether it's possible to change. Is that okay? Okay. I'm turning off my microphone and on again. Shall we now have our report from the NHS from Colin Edwards, who's substituting for Heather Howells, and Gary Failure. I assume Colin will go first. There's two separate reports in your pack and one follows another. So I'll leave it first. Okay, thank you.
Okay, thank you. Can you hear me?
Yes, we can hear you fine.
Oh, brilliant! And you've all got the slide, and you've all got the slides in front of you.
No, we haven't. We haven't got the slides in front of us, so you'll have to share your screen.
Oh, okay. I'm just sharing my screen. So can you see it on the screen?
Not yet.
Oh, right. Okay.
It is in the pack.
It is in the agenda pack, so we have. Oh, okay.
Okay. Can you see it now?
Yes, we can. Thank you.
Right. Okay. That's great. Thank you very much. I'm terribly sorry that Dr. Heather Howells was unable to join us today, who's a GP in West Berkshire, and is also the GP clinical lead for mental health, dementia and learning disabilities for the ICB. My name's Colin Edwards, and I'm head of joint commissioning, which includes mental health and learning disabilities. And what I really wanted to do initially was to focus on introducing mental health and community work across West Berkshire. And the 5 slides that I'll briefly go through, because you've had a chance to look at them, will provide some insight and background to the presentation. Some of the more detailed data will come in the second part when Gary covers the slides from BHFT and looks at some of the direct work. But this is really about introducing some broad themes so that we get a broad overview before we look at the detailed data. And we've also got Dr. Sue McLaughlin, who's covering suicide as well, which will take a slightly different slant. So perhaps if I could start on the first slide and introduce the Mental Health Integrated Community Service, which provides specialist mental health support in the community, focusing on resilience and recovery. And it's a collaboration of GPs, mental health professionals, pharmacists, community connectors, psychiatrists, psychologists, the voluntary sector, as you'll see when we go through the presentation, and also colleagues in the local authority. What we aim to do is offer support to adults living with difficult challenges to their mental health and life, including those with a significant mental illness. and those with life events significantly contributing to poor mental health, such as financial worries, relationship breakdown, housing issues, and some of the areas that colleagues from public health just covered earlier, and those who struggle to engage with other mental health services. The support includes short-term one-to-one and group sessions, which may include appointments with specialists, for example, psychological assessments, care planning, information, guidance around some of the emotional and physical well-being, and access to consultation from a psychiatrist or a mental health pharmacist, support with medication, which is critical, and bridging support referrals to other services. Perhaps if I move on to slide 3. This really covers the rollout, which has been introduced in a phased way and started initially in Wokingham and Reading before it was rolled out in West Berkshire, which was in February 2024. And at that particular point, I think we had 17 referrals within 3 days, which is quite a significant interest in the service, which is good. And of course, we'll cover that in a bit more detail with some of the more up-to-date data in the other presentations. The mental health teams will be attached to individual practices and primary care networks. And I apologise at this stage for a selection of acronyms, but you'll see on slide 6 that there is a guide to those acronyms. But initially, I shall pronounce them as they should be, rather than in their acronym state. The team would take lead referrals from the mental health service, from GP practices, talking therapists, and other community and voluntary sectors. Although they do not accept at this particular stage self-referrals. Their aim is to see patients who are referred to them within 4 weeks, so that's the timescale that we initially operated on. As I said earlier, it's on a phased rollout, initially just taking referrals from secondary care. The next phase includes referrals from primary care and voluntary community social enterprises, which is planned in June and has already obviously passed now, so it's current. The team currently has 3 mental health practitioners, a psychologist, a consultant, and they're trying to fill some of the other available roles, and we're having a degree of success in some places. One of the significant challenges to the service rollout has been the recruitment, and the team are working hard to overcome this. And the Community Wellness Outreach Health Checks service assesses mental health and well-being and refers on as appropriate. And it's quite interesting that we do the mental health as well as physical health assessment, which is part of the national drive. Moving on to slide 4, briefly looking at community connectors. These are specialist voluntary sector partners with the mental health teams who have expert knowledge of the local area, and we will have a network of those across West Berkshire, and we work together to access local support that meets the needs of patients. And it includes drug and alcohol support groups, debt and housing support, social networks to combat loneliness, and volunteering opportunities. The peer support service offers a one-to-one peer support to people with significant and long-term mental illness. The support is provided by trusted lived experience practitioners, which is quite critical. So in other words, practitioners who have been through mental illness themselves and are able to offer a fair degree of insight and support, which sometimes professionals are not able to provide, and it complements the service that we offer. And sessions can be face-to-face in the community, or they can take place online following post-COVID. And then we have the Voluntary Services Workshop, which took place on the 16th of May, which was focusing on mental health and well-being, and also linked into the NHS England's Navigator scheme, working collaboratively across the whole of the Berkshire, Oxfordshire and Buckinghamshire system. And then just moving on to one of the final slides, looking at ARS, the mental health practitioners, which ARS stands for Additional Roles Reimbursement Scheme, which was introduced in England in 2019, which again is part of a national drive to improve access to general practice. The ARS mental health practitioners are part of a wider transformation and expansion of community mental health service. Experienced practitioners who are employed by the secondary care mental health provider, which is, as we know, BHFT, but jointly funded by primary care and BHFT. So it's a joint funding partnership, which is critical. It operates as a fully embedded member of the primary care multidisciplinary network and sits within GP practices. So it's available at the point of delivery, which again is critical. It acts as a bridge between primary and secondary mental health services and can facilitate onward referral to a range of services to meet the patient's needs, as well as providing short-term treatment therapy. And we'll hear a bit more about that in Gary's presentation. Most practices in West Berkshire now have an Rs mental health practitioner within their team, and patients can directly book an appointment with them via the GP practice or be signposted to them by the GP if presenting with lower level mental health conditions. The feedback from both patients and GPs is that the roles have made a significant impact in care and support for patients with mental illness within communities. And the role has significantly improved communication between primary and secondary care services because the practitioners sit within both services, and this has significantly benefited patient care. So thank you very much. I'll pass you over to Gary, who will cover a little bit more detail about the data that sits behind what I've just covered.
Thank you very much for that. I've just noted that I'll go back when you finished your report, but I didn't ask Adrian Barker, who's with us today, for his comments as chair of the Mental Health Action Group on the public health one. So I'll let you finish yours and then I'll go back to Adrian to see whether he has anything to add to the other report. So apologies, Adrian. Thank you.
Can I assist by sharing the slides, Gary?
Okay.
Getting there. Just bear with me 1 second. Can you see my screen?
Not yet.
Okay. Could you please share the slides?
Yes, no problem.
Are we ready?
We can see it now. Thank you.
Okay. So just bear with me 1 second.
I don't know whether it can go any bigger.
Okay. If you put a slideshow, maybe. Okay, thank you. Shall I start? Okay, so the community mental health services in, sorry, would you like me to introduce myself, or do people feel they know from the introductions at the beginning?
Yes, you want an introduction? Yes, they want like a reminder. Thank you.
So my name is Gary Farley-Funtulaki. I'm a psychiatrist and I'm also a clinical director for BHFT. And my portfolio includes community mental health services and the services that are attached to them that we will go through. So the community mental health services provide a broad range of services, and they involve medical, clinical, psychological treatments and interventions. And we work very closely with acute services and crisis services, but also with primary care to make sure that service users get the right care at the right time. And we accept referrals in West Berkshire through a service called Common Point of Entry, or Gateway is the correct name at the moment. And anybody that is registered with a GP in West Berkshire is eligible. Next slide, please. So you can see here a diagram of all the services that we have in mental health for working age adults, so not children here. And you can see the the yellow diagram shows what is available in people that have lower need, if you like. And as we go to the right, the need increases. So on the left side, you can see people that are experiencing mild stress and need support with their well-being. And they have access to self-help groups like the Every Mind Matters scheme, and low-level support through their GPs and through the ARS specialists that Colin mentioned. So they might need social prescribing or input from link workers to attend to their social needs. And then the blue diagram shows you people that come through with common mental health problems, for example, mild anxiety or depression. And they can access talking therapies through the NHS for the anxiety and the depression. And if they have longer term conditions, there are pathways there that they can access and also support for their employment. And then you can see in the green slide, we have what the classic, if you like, community mental health services provide. These are for people that have more severe mental health problems, for example, psychosis or bipolar illness, or complex emotional needs, eating disorders, treatment-resistant depression, anxiety. And they really benefit from a multidisciplinary approach and treatment. So at that stage, you need perhaps more than one clinician to be involved. So they can get support through their PCN with the schemes that Colin mentioned, like the ARS workers and the mental health integrated workers. They can have also support through the core community mental health services, and those will include the early intervention in psychosis, psychological therapies, employment support. And we also have specialist services, for example, specialist services for eating disorders or for complex emotional needs, etc. And alongside all that, we've got our crisis services, and they are relevant to people that pose a risk to themselves or somebody else. They're available 24 hours all through the year, and they manage the acute presentation of mental health issues. Next slide, please. So on this slide, it's just a summary of all the things that are available in West Berkshire. We've been through most of them, I guess. Perhaps if I draw your attention in SUN, which is the Service User Network, Let's Connect, that is a social enterprise bringing people together. They're not specific for patients with mental health problems. It's for, any citizen can access that. Then we've got the Liaison and Diversion Service that aims to support people that have interface with, service, probation, through the courts, really. And other services there that we sort of mentioned already, or we will go through in a little bit more detail as we move along. Shall we move to the next slide, please? Where you can see the Let's Connect service, which, as we said, is it's a well-being network. It meets in Newbury Corn Exchange every 2 weeks on a Tuesday. And they also offer individual sessions online. And you can see the number of referrals on the left-hand side. And yes, you can see that there has been some significant fluctuation as the months go by. On the right part of the slide, you can see the individual placement service. And there are people that support patients to find employment, or stay in employment if they have difficulties with their current employment. And you can see the referrals, and also you can see the current caseload, that is 17. And in that month, 8 people had been helped to find employment. Thank you. The next slide is about the service user network. And there are some quotes, positive ones from people that have been able to use the network. So this is very much aiming to support people that have issues with emotional dysregulation and could have had completed therapies already or not. It is very much based on support by members, service users and clinicians. And it's a program that is open. It happens either face-to-face or online across Berkshire and, of course, in West Berkshire. You can see there's some positive comments. Next slide, please. So this one is about talking therapies, the IAPT service. On the left-hand side, you can see the number of referrals, and you can see that the access to the service is gradually increasing. However, we have a target of 197 people as an average, and we have been not quite meeting it with 177 each month. Now, the waiting times for assessment are currently 2 weeks. We managed to see people within 2 weeks, and 70% of the patients will start a step 2 intervention. We'll have a step 2 intervention, and a step 2 intervention, for your information, is CBT treatment, which could be online Silver Cloud. For that, we don't have any wait, as patients are given instant access from the point of assessment. And they can have an alternative would be guided self-help. This is mostly done through the phone, and for that, there is 4 weeks wait. Then we've got a step 3 intervention talking therapies, which is CBT 16 sessions through online consultation, or counseling for depression, which is again online 24 weeks. So we do currently have waiting times for the step 3 intervention, and we're currently working to improve those. Over the last 6 months, 52 of the patients that have an intervention with us recover, and that is the national standard, is 52 weeks. Then on the right part of the slides, you can see the Managing Emotions program. Now that has 3 levels. It's delivered by Together UK, which is a voluntary sector organization, and by BHFT staff. And it could be both face-to-face or online treatments. It has 3 levels, if you like. Course 1 and 2 is delivered by Together UK. Course 3 is delivered by BHFT. And we offer online groups, psychoeducation workshops, DBT, etc. And you can see there the numbers, although the print is quite small. Right, if we move to the next slide, you can see the numbers for mix. So on the left is the number of referrals. You can see where it was launched, and you can see how it went up, and you can see the size of the caseload on the right graph, and you can see that that is progressively increasing. So in Mix, we also have community connectors that are supported through Mind. In West Berkshire, we have one colleague that started in their induction in August 24. And we have a second community connector that was starting in September. So we expect that they are working as well. And we've got one vacancy that we're hoping to recruit to. There was an advert that went out last month. We don't have any waiting lists as such, but we do breach sometimes the 2-week to assessment aim. And part of the reason for that is that the people that come through Mix are progressively big. We identify that have more complex needs and they need more MDT input. Right. So the next slide is about the adult CMHT. So this is the community mental health team for our working age adults. And you can see the number of referrals. This is for first, this is specifically for psychiatric input. And you can see the caseload of the team, which is 743, was at the beginning of the summer. So the waiting list for psychiatric assessments is at the moment 12 weeks, which is higher than what we would like it to be. And the waiting times for care coordinators is 6 weeks. We move to the next slide. We've got some information about early intervention in psychosis. You can see specifically for West Berkshire, we get a couple of referrals per month. They have a caseload of 12 people, and they have a waiting list, a waiting time of 1 to 2 weeks. So they pick up the patients fairly promptly. There's a small team that has some specialist knowledge, but the aim is to be fully integrated within the general CMHT. And then on the right part of the slide, you can see our crisis team referrals, and that's for West Berkshire. You can see how they fluctuate in the months. And then as a sample, we gave you what the caseload looked like on the 1st of August. And on that day, they had referred, so they had received 3 referrals. 2 of them were particularly urgent, and you can see the numbers go up as the referrals are a little bit more settled, because that includes the people that are getting ready to be discharged back to other appropriate services. And then you can see a slide on impact, which is an intense management of personality disorder service and clinical therapies, it's called. So that's a specialist service, and you can see the that the numbers there of referrals coming in. On the day that we got the data, there were no people waiting for an initial appointment. There was one patient waiting for MBTI, which is the introduction to mentalization-based therapy. And there was one patient that had completed their MBTI program but had deferred treatment for 6 months. And there were 4 patients that were waiting for DBT, which is dialectic behavioral therapy. And the longest wait is also there, which is significant. We've also got psychologists that are integrated in the community mental health. So they are the community mental health psychological therapies. The longest wait at the moment in August was 25 weeks. The longest wait for assessment, that is for treatment, was 11 months. For group sessions was 4 months. The total number of people waiting for individual therapy were 12, but there were 2 more people waiting for groups, so that was a total of 14. And the current caseload of that team was 99 people. There was some recent restructure of the community mental health psychological therapies to facilitate efficiency and help manage those waiting lists. So we hope to see them improving in the near future. And if we move on to the next slide, which is that of the older adults community mental health teams, and you can see the number of referrals on the left. There have been around 25 in the last couple of months. So we do have the caseload there that you can see on the right-hand side, 245 in July. We do have waiting times, but the people that are referred urgently are seen within 1 week. And then we have people in a category that need to be soon enough, and we managed to see them within 2 to 3 weeks. And then we have the routine referrals, 3 to 4 weeks. The next slide is about the memory clinic services. And there we have waiting times of 17 weeks, which is an improvement by comparison to 24.5 weeks we had in December, but still not where we would like to be. We would like to see people with memory problems within 6 weeks. You can see the number of referrals coming in across the months. Right. The next slide, can you see the I Want Great Care slide? So I Want Great Care is our feedback route, and you can see that we have been getting 28 responses. This is data for 2024, and 82% of those were very positive, and we had an average of 5 stars, a score of 4.3 across all the questions. So we had in the overall community, we had 54 responses, and again, a very positive average. From the memory clinic, we had 87 responses and good feedback. And then you can see the numbers for MICS and OBMH services. And then on the next slide, you can see some free text comments that people have put in their feedback, which are primarily positive. And then on the next slide, you can see the context and challenges. So there isn't any opportunity to train in nursing in West Berkshire. So we have to attract students, if you like, into this area. And we have had vacancies that are a result of national shortage, both in education, establishment across West London, Oxford, and then the need for people to relocate in West Berkshire. We've got demand increasing, we've got an aging population in the area. But on a positive note, we've got mixed teams working in GP surgeries. They do struggle to find space, like physical space, rooms. And one of the ways of managing that is by offering online appointments, but they cannot, they're not ideal for all service users. They can be used only by some. Then, as somebody alluded earlier, this is a big locality, transport times, access, sort of make it harder to offer face-to-face contact, which is our gold standard. It's a rural population in some places that would find it difficult to access centrally based buildings. And then, if you take into consideration the staff traveling time, people sometimes need to travel an hour to go to places like Lambourne. So we try and plan our visits so we don't waste too much clinical time on traveling. Then there's some issues with the public bus routes to Hillcroft House. I understand they're roughly 30 minutes from the town centre. Other challenges would be finding space in rural communities and etc. And then funding is limited, so finding other locations that would be accessible across the geography, can be difficult. Right. The next slide is on One Team. Can you still hear me and see the slides correctly? Yes. Okay. So One Team is a service transformation. What it does is, just bear with me 1 second. So what the One Team aims is to bring all of the services that we mentioned already to work closely together and have less transition points, which is where communication issues can become difficult and delays that are unnecessary can build up. So we launched that a few months ago, and it was based on the transformation work that had already happened. And it's a new model for Berkshire. You can see how we try to provide some clarity and of what should be an individualized and evidence-based high quality intervention. We want to have clear pathways and interface arrangements. We want to offer holistic care that includes the social needs, the physical health, and focus on recovery. We try to eliminate unnecessary thresholds such as age barriers and facilitate transformation across the teams. We are working across multi-agency boundaries, and we aim to provide earlier interventions and easy access and a smooth interface between primary and secondary care, and of course being all-inclusive in our approach. So in the next slide, you can see what it is that we actually offer. So we offer services at place. So we have a new One Assessment and the form that goes with it that has gone live, that identifies people that have significant mental health needs. Post that assessment, so the patient will be assessed face-to-face by a clinician, and following that there will be an MDT discussion where there will be joint decision making, and there will be some recommendations and a treatment offer that will start very quickly. So we also have MDTs where we can go for escalation. So if there is any dispute or uncertainty, these are attended by even more senior clinicians that can discuss complex issues and the risks that arise. And we offer, we hope that we communicate to referrals with a very clear rationale for the decision that we have made. There is support through digital flow and sort of monitoring our times. We also have a new approach to risk formulation, and we have an emphasis on safety planning. And we try and pair the questionnaires that patients send themselves and the clinical codes so that we can monitor the effectiveness of the interventions that we use. We started some work within our older adult services in anticipation of perhaps some new treatments that will become available in the future for dementia. And we want to address any variation in our waiting lists. And our mixed colleagues are now established in working closer with primary care, and they facilitate the transfer of patients in secondary services, but also out of secondary services and the support that they need after that. Okay, thank you. I appreciate these were quite
Okay,
a
thank
lot
you
of slides.
very much. Assume we can call you Gary as
Yes, you can for ease, yes.
Yeah, and thank you for the glossary. I mean, there are an amazing number of acronyms, and I felt I was constantly going backwards and forwards looking at. I don't know whether there's any way to reduce that. We Googled SNOMED to see what that meant. The one about digital, whatever, systemized nomenclature of medicine. Well, even the glossary doesn't really explain what that
system. Yes.
You sort of mentioned that in your presentation.
So this is really, Yeah, so if I can put it in context, SNOMED, if you like, is the diagnosis, a code given for the diagnosis. And the importance of that, in my mind, is being able to look at your data and think, well, for the people that have diagnosis X, for example, what it is that we offer, do they improve? Do we follow the most evidence-based treatment? Is that an appropriate pathway? Do we need to be doing something different? Is there a part of their need that we don't meet?
Well, thank you. I mean, we appreciate, and it's a very detailed report, but I don't know, we do wonder whether it could be simplified in some way to make it a little bit more accessible to sort of possibly lay people like ourselves. But we do appreciate that that's difficult when you've got such a lot of information to give to us. So we're going to go back now. Before we start questions, I did say that I didn't give Adrian a chance to say anything after Rachel. So Adrian, would you like to add to Rachel's report? So we're going back to the public health business.
Thanks, Chairman. I won't take up too much of your time, but just briefly to explain what the Mental Health Action Group does, and just to make a couple of more general points. The Mental Health Action Group, for those who don't know, is a subcommittee of the Health and Wellbeing Board, and its role is to support the Health and Wellbeing Board in relation to adult mental health, which is mainly about helping to oversee the implementation of the joint local health and wellbeing strategy, one of which has 5 priorities, one of which is adult mental health. So we are helping with the delivery plan for adult mental health. The members include Berkshire Healthcare Foundation Trust, the council, several representatives from the council, and various voluntary organisations. So we're trying to take a sort of a whole system approach, which is a bit of jargon, but basically it means it's not just about the services that directly support people with their mental health, but all the things that impact on people's mental health and all the people involved, which is a wide range of voluntary organisations, but also the people who are suffering themselves, sometimes dealing with the problems themselves, not going to services, and their families and friends and people who care from them. So we're trying to take that big perspective. So we have done a number of things. We've been working through the delivery plan, which came out of the strategy, which was agreed a couple of years ago, 2 or 3 years ago. And the delivery plan is due to be revised shortly. So we will feed into that process and see if there are better ways in which we can deliver some of the things which are in the strategy. Just a couple of points where I think there are not so much challenges. Well, I think a challenge for everybody everywhere, but where I think we probably need to do a little bit more. One is about strategy and the other is about partnership. But just to preface that by saying, applauding all the good work that has gone on in terms of partnership. Examples including the one team approach that Gary was just talking about, which has brought BHFT have been very good about bringing people in on that. The Mental Health Integrated Care Service has had a steering group operating since before it went live, which again brought in a wide range of stakeholders. The Mental Health Action Group has been involved in the Mental Health Place Board, which covers West Berkshire, Reading and Wokingham. So there's a lot of really good work. And it's not to say that we're behind what other places are doing, but I think to be successful in mental health across the whole system, we need active commitment and buy-in from all the players to the strategy and involvement in the processes. And there's perhaps some things we can take offline with BHFT about involvement with the Mental Health Action Group. But it's a constant challenge, I think, for everybody to make partnership work because it is difficult. And the strategy approach, I suppose, is we have a strategy, we have a priority, but I think we could do with more about the big picture of where we're trying to get to over the next 5-10 years and how the various bits of what everybody does fit into that and are leading towards change. So I'll leave it there. Thanks, Chairman.
Thank you very much. I could see lots of nods from your partners on the screen as you were talking, Adrian. So obviously your message is going across. So we move on to questions now. Can I go back? Can I just kick off a bit with a question about the graphs at the beginning of Rachel's report, which graphs, obviously some of us are more challenged with graphs than others, but the first graphs that you give us on page 16 and 17, and you refer to, you're comparing West Berkshire's statistics with other authorities, and I'm assuming, although it doesn't explain it, the green and the amber are the sort of like green, amber, red, so they're showing that we're not too bad in the stats. But by neighbours isn't like next door. Neighbours is meant to be people that are similar to us. Is that the idea? Okay.
Yeah, that's right.
So I don't know whether other members had any issues about those graphs. Okay. Have members got any initial questions before? I've got some. I don't see any hands going up. I mean, sort of generally speaking, I mean, the overall thing, I mean, we've had the public health perspective and we've had the NHS perspective. And obviously the issue of funding for public health is always a big one, sort of versus the NHS when it's considered to be so important. That's probably too big an issue to consider here. But there's an awful lot sort of going on, and you know, my own thinking is that the public health aspect of things is possibly maybe the more important one. I mean, is there a struggle with resources in any of the aspects that you're doing, Rachel? There must be, really.
That's a good question. I'm not too sure how to answer that, but we do have some allocated budget within the public health grant to allocate to public mental health. I could let the board know that we are due to be launching a new mental health fund with Greenham Trust soon, and that will provide some funding to voluntary sector organisations to bid for funding that will support residents' mental health across West Berkshire. So at the moment, that's one of the main things we're focusing on. But yeah, just to reiterate, there is some spend available to us that we can use on public mental health initiatives.
Okay. All right, thank you. Is that Jamie? Is that? Oh, that's. Please carry on. Yes, Matt. Thank you. Our public health lead. Thank you.
Yeah, thanks. Can you hear me okay?
Yes, thank you.
I just wanted to build on what Rachel was saying. I mean, obviously, we'd always like more money in public health because obviously what we want is the focus to be more upstream and tackle the causes of ill mental health. But I think for me, it's building on what Adrian said. It's how we maximise the levers we've got across all our different organisations, our agencies and our communities. So as we know, poor mental health, you know, it's led because of poor housing, unemployment, trauma in childhood. It's very complex. I think it's not always about the money. Money absolutely is really important, but it's actually how do we get those partners to embed how do we support people with good mental health across the whole of the life course and the opportunities they have in engaging with our service users. So I think for me, it's about that whole system approach, which Adrian's talking about, because you can't really separate mental health from everything. It's embedded in all that we do. It's very similar to health inequalities. So I think it's, as I say, how we lever those opportunities across our partners and those agencies and our communities, and to maximise how we can best improve people's well-being.
Thank you very much. Yes, I suppose that's sort of what I was thinking. I mean, a lot of, we want to prevent things from happening rather than just sort of chasing them down the road and having lots of crises. I mean, on page 18, I mean, we see that severe mental illness that West Berkshire with adults is higher than the national statistic. And that's quite alarming that in this relatively well-off area, this is 2.7, we have this high statistic, and we know that self-harm seems to be high in our area. Is that mainly among young people? Is this to do with COVID? You know, I mean, that's quite a disturbing statistic. And one of the things I was going to ask is really, I mean, we're looking at COVID at the moment and the effects of COVID. We're sort of reviewing what we did. And if we've got a lot of mental health issues among young people because of COVID, we can go back and we can look at what we did, particularly in our schools during COVID. You know, they missed school, the absenteeism in schools. If we have another pandemic going down the line, which is not, you know, which is probably quite likely, can we please, if we're, I don't know what's going on in the COVID committee, but could we please think about what we did to handle schools and young people during COVID? Can we not do the same again? Because it's had a very, very severe effect on our young people. So I hope that is something that's being considered in the whoever is looking into COVID. And I'm not involved with that, so I don't know whether it is. I was on the initial LOEB. And just, I don't want to hog this, but just, again, thinking of young people, I think it is mentioned in the report about the importance of not forgetting about parents when you're talking about people involved with young people. I mean, they are their first teachers. It's just sort of a line in the report, but I think we need to be thinking much more about how we're supporting parents. We know that under 2 years is the most crucial time in a young person's life, and that's parents and carers. But we haven't got enough support in family hubs. We haven't got enough health visitors. You know, again, during COVID, parents and babies suffered because they couldn't get the one-to-one contact. So, and we're supposed to have an early years health inequalities group, but as far as I know, it's just not happening. So whoever's responsible for that, and we haven't got Anne-Marie Dodds here, so can they please find out what's going on with such an important group? And, you know, I've inquired about it, and so far I've had no response to this. But I'll see what other, I don't know if anybody wants to respond to that, and what other members have to say too. Thank you. Yes?
Yeah, sorry. Yes, I've got a couple. Starting with Dr. Funtilaki, one question is, you mentioned space in rural communities as being a problem, which I can imagine. We're in one of the villages that is in the east of the district, and I kind of assume that, do I correctly understand that all the face-to-face elements of the various services you've described go on at the Hillcroft site, so that folks like ours would go there? Because I'm thinking that much as we'd like to have something more local, that's probably not practical. Do all the activities go on in a place like that, or do they not?
It depends on the activities. So, you know, if you like, the medical appointments would either happen in Hillcroft House or they will happen in the patient's home. You need, you know, soundproofing, you need appropriate safety and numbers. You wouldn't go and see a patient that has increased needs in a place that is not suitable 100%. But there are activities that are happening in the community, like well-being groups, you know, the community connectors, etc. The issue that I raised about access is also within primary care. So in a GP surgery, our mixed colleagues may not have space to book a room. There might not be enough rooms available, and they might have to invite these patients to come into Hillcroft. In the rural areas, we would be able to run groups and, you know, have activities that would be suitable for people that we don't always have enough space to offer.
I see. Thank you very much. And just another question is on the, it's probably more on the earlier presentation about the Community Connect and the sort of lighter or the lower level mental health issues. Would I be right to understand that somebody, housing I noticed was mentioned, if somebody had a sort of stress issue relating to housing, particularly social housing, would that be, does that sit in that category of Community Connect, and do those folks self-refer in those kind of examples, or would you expect them to go via primary care, or is that not a correct example in the first place that I've just given?
A community connector would be able to advise and support the service user to access support for their housing. They won't be able to organize housing for them, but they will be able to guide them and show them what's the right pathway to pursue this and support them in doing so.
Yes, I'm thinking, yeah, specifically mental health related, not get me another house or something, but someone who feels there's a problem with where they live. That is in the area of, so they would find a community connector directly by looking them up on the internet or something. Is that how it works?
No, we would provide a link to that community connector. We would, you know, I'm not sure I follow the question, but if this is a patient that is open to other services and is already in contact with our services, we would guide them to how to find the community connector, or we could make a referral to the community connector ourselves.
Yes, and sorry, finally on the one, I forget what it was called, the initiative, the one integrated.
The one team.
Yeah.
You mean the one team initiative? Yeah.
Yeah. Do you think, do the teams themselves not change under that proposal? Is it just, and I say just, it sounds quite good, the ability to move patients from one team to the other and back, and the teams talking more closely together? Is that the principle? Do you believe the teams themselves would stay as they are now under that model?
So the model involves the teams, if you like, having sort of changing to a degree. So we don't want the teams to consider themselves very separate from each other. Therefore, you know, sort of having a boundary becomes less of a problem. So we don't want clinicians to be thinking of, this is not something that I can do and I have to refer to somebody else. We want people to be in the same room at the same time, so one decision is made without too many different meetings where, you know, a different team needs to be consulted and a different team needs to be consulted. The leadership and the boundaries of the team are reconsidered. So if the teams are coming together, you know, there might be efficiencies in terms of how many leaders we need. And there is an expectation that those initial assessments that we do are done by senior people that can provide high quality assessments, because this is the first and paramount step, really. Does that answer your question, at least partly?
Yeah, that's great. Thank you very much. Thank you.
Thank you very much, Nick. Yes, I mean, I was going to... There's a mention of village agents here, and I didn't know that village agents were still functioning, but obviously they are, because I was aware of village agents in the past. I was also going to ask Adrian about the work that he's done in the past on helping people with mental health issues and debt, because I think that's quite an important one. And certainly, you know, in our present anxieties over the cost of living, this has been raised at the Council's Poverty Forum about how people access benefits. So it's not just, even when you know what's available, actually filling in the forms and being able to navigate a 40-page form is absolutely crucial in getting the money that you need when you're in a crisis. So is there any work going on between possibly the Mental Health Action Group, Citizens Advice, anybody else in basically tackling, probably government here, in simplifying the forms that people are faced with when they're in crisis? And if you've got mental health issues, this is going to be even more crucial. And I know in the past, Citizens Advice had their own particular advisor that worked with people with mental health issues, because they realized that they were going to be more challenged and needed more care and time than others. And that service went a long time ago. Obviously through lack of funding. We fund Citizens Advice, the council, but probably not enough. And anyway, this particular service went some time ago. So Adrian, have you got any comments on that? Thank you.
Yes, thanks, Chairman. Yes, we did produce a report on financial problems and mental health, which went to the Health and Wellbeing Board in 2023, last year. which had a number of recommendations. I think one of the key things, we talked to a lot of stakeholders, and it was the interrelation of all the problems, which was difficult. You need to be able to sort of almost tackle everything at once. You know, the financial problems impact on mental health impacts on, you know, not being able to manage your financial problems. There may be substance abuse, housing issues, and so on as well. So it's not something where there's an answer. It's something where that we need to keep working on it. But we did make a number of recommendations. But just to come to your other point about the form filling, this was recognised by the Mental Health Action Group earlier in the year, and we had a workshop a few weeks ago, and a very good attendance. I think 16 or 17 different people there from a variety of organisations, including Citizens Advice and DWP. And I think the response we got was an indication of what a problem it is for people. A lot of these organisations are having to sit down for, you know, a couple of hours to fill in some of these forms. So we, Rachel might be able to say a bit more, but it was a very useful workshop. A lot of it was about getting information out, starting to come up with ideas, but we do need to do some more work on how we can actually come up with some answers on that. And I think as you were indicating, you know, the ideal is that you don't have forms that require 2 hours to fill in, but in some cases there are just processes you have to go through and checks that need to be made, and they are going to be difficult. And you know, if we can find ways of helping people with that, and at the same time, sometimes it's helping them with a wider range of issues. You know, some of the people who came to the workshop said they'd spend an hour talking to them. It might be from Sovereign Housing, for instance, and they'd be talking to them about the housing situation, but they'd also help them with some of these forms, and you know, it all sort of, they each help each other.
Thank you for that, Adrian. But maybe at another level, it needs to be looked at. These forms have to be so dense and complicated so that people are deterred from claiming the benefits that they have every right to claim. Can I just go back to I think in the report it says that as regards the access to the whatever it's called, the practitioner who will that's based in the surgery, the equivalent of the CPN or whoever you need to see. So that it says most people have access, and you talked about not all surgeries having facilities. If your surgery doesn't have a facility, and can you go somewhere else? Does it have to be basically, you know, I don't know whether you touched on this, but everybody should have access to these practitioners that can help them in need. Or can partners, can we as the council, are we working hard enough to make sure there are facilities? Possibly is there more that can be done by, you know, by looking at this, if this is a problem?
Who would you like to answer this question? Would you like me to say
probably you, I think, isn't it? Yeah.
So, you know, if there is a patient need, we will try and meet it. If the patient doesn't have access to ours or mix, the GP will pick up the need and refer to us. And through our work, we will meet this need. The patients will be missing out on how easy it is to access that. And, you know, for example, they might have to travel a little bit more, or there might be a delay, but we will try and meet this need. If they don't have, if they don't have access to the specific pathway, because, you know, that's not available to them on the basis of where they're registered with their GP, we will find an alternative, but it's not as easy or as straightforward.
I can see that, but obviously, hopefully you would work with us and other partners to try and find facilities where people, I mean, we're talking about having hubs in the town centre for you know, where everybody can access things. That's sort of not happening, but it might mean maybe with a little bit of, you know, something from yourselves, talking to the other agencies, we can all maybe progress that so that there are places that people can access easily and they don't have to, you know, if the GP doesn't have anywhere.
Yes, and we're doing a lot of networking with within primary care to try and emphasize what are the benefits from mix, or having ARS colleagues based on their, because the ARS colleagues, if I can sort of add, are actually working right next to the GPs. They have space, they have rooms, they see patients instead of the GPs on the day, if that's clinically appropriate. So they're very, very much embedded within primary care. And most of the GPs surgeries really value their input, and they get quite a lot out of having them embedded in the service. But we do a lot of networking to try and highlight which patients benefit from ours, which patients benefit from mix, and why they should have that. And we support the process. So, for example, the ours colleagues are funded partly from primary care, partly from us. And we offer supervision, reviews, whichever way we can support the process, really. But to go back to your original question, if the paper, if there is a clinical need, we will not be particularly hung up, but, oh, you come from that surgery, we cannot do it. We will find an alternative way of trying to meet that need.
Thank you very much. That's reassuring. And thank you very much for your report. Thank you. I mean, there's so much in all the reports, really, that we sort of feel that we can't really I think we'll probably have thoughts after the meeting. We might get back to you and see what further information we might want in the future or further. Yes. Thank you, everybody. Yes. We have to move on now to an associated report. Sadly, when a lot of things haven't worked, we get to what we do to prevent suicide. And we've got, I think we've got Stephen Bow and Sue McLaughlin here to present their report. Thank you. And sorry that we're a little bit behind time.
Thank you, Chairman. So I'm Stephen Bow. I'm the consultant in public health for West Berkshire Council. And you've had the paper on suicide prevention. I'll just give a brief commentary. So in West Berkshire, we have about 10 or 11 suicides per year, which is, it is a small number, but each one has a significant impact. And suicide accounts for over a quarter of male deaths in the 30 to 34 age range. So what do we know about these suicides? So there's always a delay between the deaths occurring and the information on cause of death being published by the Office for National Statistics. And this is particularly an issue for suicides or suspected suicides because they require an inquest and can take many months before a coroner's verdict establishes the cause of death. So to allow more timely action, we have a local real-time surveillance system, which is abbreviated to RTSS, which allows the organisations involved in suicide prevention work and responding to suicides to review incidents very quickly so that trends or patterns can be spotted and acted on as fast as possible. And we also periodically conduct suicide audits in which the coroner's reports for all suicides are reviewed in detail. So apologies that the detail of this wasn't included in the report that you've got, but I can give a verbal outline of some of the findings of the last suicide audit that are of note. And this was a Berkshire-wide assessment, so the data refer to Berkshire as a whole unless specified. But broadly, the gender pattern matches the national profile. About 78% of suicides were male and 5% were transgender. 30% of West Berkshire suicides were in the 40 to 49-year-old age band. About a quarter were in full-time work, about a fifth were unemployed, another fifth also were retired. And 6% of all people included were recorded as being in education at the time of death. So the 2018 audit, which the plan is to refresh it next year, highlighted the following personal and social factors as seen on a recurring basis in inquest reports. So relationship difficulties, 67%, one or more mental health diagnoses, 63%, one or more physical health conditions, 61%, history of self-harm, 21%, work-related stress, 20%, financial issues, 19%, involvement with police or courts, 15%, and bereavement by suicide, 6%. In addition, 10% of all individuals were known to substance misuse services in their lifetime. 20% had a documented history of alcohol misuse, and 17% had a documented history of drug misuse. About half of those who died and who were registered with a GP had seen their GP within 1 month prior to the date of their death. And 36% of all deaths occurred to people known to mental health services. So, I mean, one of the biggest challenges is that suicide is a really complex issue, and the contributing factors can be addressed to some extent via the health and social care services, but the wider drivers related to a person's personal and social economic well-being are really significant. A number of local services and initiatives are mentioned in the paper. I just wanted to pick up on one point and would like the committee to note that the ICB funds the Amparo bereavement support service, and there's a feeling that this is a good provider providing a really important service, and you'll see it actually on the bottom left of the leaflet that Rachel has provided those who are in person today. And just to highlight, the contract's been extended till July 2025. But as things stand, the ICB hasn't been able to allocate the money to continue it beyond that point due to the financial pressures. And we're currently working with ICB colleagues and counterparts in other Berkshire local authorities to develop a business case to make a case for funding that beyond that point. More broadly, we've got a pan-Berkshire suicide prevention strategy with an action plan that's owned by the Berkshire-wide suicide prevention group, of which I've just taken over as chair. And the intention is that each local authority below that will develop a local action plan, and there's an audit tool provided as part of the strategy that can be used to identify strengths and gaps in the local system. The intention in West Berkshire is to develop this through the West Berkshire Suicide Prevention Action Group, which is an existing local authority, voluntary sector-led multi-agency group with good engagement from partners, and this is also a subcommittee to the Health and Wellbeing Board. And in this paper, we're asking the Health Scrutiny Committee to support the development of this action plan and also comment on some specific questions to help direct its focus around local priorities, actions, funding, and risks.
Thank you very much, Stephen. It's worth noting, actually, while we're discussing we're concentrating on mental health today, that there's been a survey, a national survey, there was something in the papers, I think today or yesterday, that the public are now more concerned about mental health than they are about obesity and cancer. So they've done a survey, and it used to be cancer and obesity that was prevalent in people's minds, and now it's mental health. So I think that sort of really shows that how much concern there is. This is probably post-COVID. Yeah, so it's so I think that's something that we should all bear in mind. I particularly like the graph in the report, the iceberg graph, which just shows how much is under the surface. And although you say the numbers are really low and every one is a tragedy, it just shows how much potential there is there for people to just tip over the edge, and you know, hopefully they're being prevented and helped by people in the community sort of picking up on this. So, you know, it shows the importance of the suicide first aid. Is that what it's called? And is it a thunderstorm? What's going on? There was a funny noise. So what's the take up of that? And are all professionals, or all health and social care professionals, are they all, is it compulsory to have this training? Is it offered to everybody?
So I don't have the numbers to hand in terms of the take up, but it is that's run through the Volunteer Centre West Berkshire, and we are now as a council providing some money to fund that going forward. But I understand that the take up is good, and there have been a number of different ways that's been delivered in the community and to different organisations, and also there's a plan to specifically deliver that in educational and school settings going forward. that it's not currently mandatory for council staff, but we are looking at whether there are appropriate training courses that we can make roll out across the council, especially for frontline staff in adult and children's services.
I know, and this probably follows on to mental health first aid courses, really. The mental health first aid I did some time ago, and it was several sessions. So I suppose it's the time that practitioners have, and maybe, you know, you have to make something fairly user-friendly and condensed in order for them to take it up. Otherwise, they won't take the time out. They won't be able to do it. And I would imagine these sort of things need to be in person rather than online, because you need to share things. And there's so much that seems to be available online. And yet, really, I would have thought you need to be sort of in the room for a lot of these things. I mean, you mentioned schools, and I think I probably meant to mention it in the previous report, that there was talk about having people in schools. And, you know, is the aim eventually to have a sort of mental health practitioner in all schools, somebody that can actually, you know, that has the experience and the expertise, not just emotional health academy, which I know we have in some schools, but I don't even think that's in all schools. Is there an aim to have a practitioner in all schools so that there's somebody there for a child that can pick up on sort of urgent things?
I do not know the answer to that. I don't know, Rachel, if you have a view on it.
We could, excuse me, we could get some more information about the mental health support teams that are in schools. Some schools have extra staff working on mental health to support students, but we can get some more information across to you about those.
Thank you, Rachel, but it really needs to be in all schools, doesn't it, really, and not just up to whether the school is really aware.
Yes, when I first became a councillor last year, my local school invited me to visit the school, and their big concern at the time was the removal of the function in the school funded by West Berkshire of a welfare officer who often used to pick up all these difficult things, not just with the children, but with their families behind them. They would start perhaps by non-attendance at school and then find all these other big issues behind that initial figure or statistic. And I understand that West Berkshire Council has removed that funding and that these people are now no longer in all the schools or operating in all the schools. And I did ask and have asked and been asking for that funding to be restored, because it's a very good place for this type of thing to start. Thank you.
Thank you, Jane. I think I'm sure officers will take that on board and sort of look into it, and maybe it's something that we need to come back to. Yes, Owen?
Thank you, Chairman. On page 71, have I understood, Stephen, from what you said in your presentation, that you are now that director who covers the whole of Berkshire? Because on page 71, it was saying we didn't have somebody at the moment, didn't it?
I'm struggling to locate the precise note in the report, but so I'm the consultant in public health across Berkshire, who's leading on suicide prevention.
Sorry, who is?
So I am the consultant in public health leading.
I think that is the point that I was trying to pick up. Can I just sort of, I suppose partly it's just nomenclature, but sometimes nomenclature can count for quite a lot. On 76, page 76A, it refers to the stigma of debt, and the implication is that there's a stigma, and that is what is worrying people. I'm going to use these words. I've been there. It's not a stigma. It's a terror that everything that you've got, everything you've been involved in, is going. It is not you wake up and think, oh my golly, I've got a tremendous stigma. Somebody's going to think I can't pay the milk bill today. It is actually, it is the terror of this bill's coming in, that bill's coming in, I haven't paid the council tax, all the rest of it. And I don't think stigma is a useful word. I don't think it's the correct word. Whether my word of terror is the right word, no, it probably isn't. But I would like to have that word in there just looked at and see if we can put something which is a bit more relevant in there.
Can I make a point, please?
Jane, that is it.
No, I don't agree with you, I'm afraid, Owen. The reason I don't is that although you, as the bill payer, may just worry about paying the bill, often children are stigmatized by the fact that they come from underprivileged or poor backgrounds. So that's what I think that report was referring to, but I can be corrected. Thank you.
I think both of those contributions are very valuable. I think what Owen said is particularly valuable, actually, and probably just shows how important sort of debt issues are when you're talking about mental health, what the big impact that it has. I hope Adrian seems to have disappeared. I hope Adrian heard that. And also, Adrian, I believe you had your hand up, and I'm sorry for missing that. And I believe Helen has a hand up too. So, Adrian, do you still have a hand up?
I didn't have my hand up. I think it was Helen, but just on the stigma point, when we were doing our work on financial problems and mental health, Citizens Advice and some other organisations did say that some people, not everybody, but some people in debt didn't come to them for help because they felt, maybe stigma is not the right word, but they felt embarrassed by it, and they felt it was a sort of a judgment on them. So I think there is something there for some people. That's what we found.
But I think the strength that Owen has expressed, I think maybe needs to be expressed somewhere in a recognition that this is not just a little bit awkward, but it is really terrifying, I think, maybe. So thank you for that, Owen. And I think, Helen, you got your hand up, is that right? Sorry to miss it.
No, I did have my hand up. Sorry, it was on the point about mental health support teams. So rewinding slightly, I was only going to flag that the work that the ICB is currently doing to review the role and place of mental health support teams within wider provision, such as the emotional health academies, and really looking at how we can extend the reach of those mental health support teams. Improving coverage and also focusing on the whole school approach, which is very much around promoting mental health and wellbeing for the whole student population. But really happy to talk a bit more about that at some stage, if helpful. Obviously, also recognising the work within the local authority who currently provide the service. Thank you.
Thank you very much. I realise we haven't heard from Sue McLaughlin. I'm awfully sorry. You're still there, that you had your own report here. I was thinking both have been encompassed. Is this Sue? Can I see Sue on the screen?
Hi, yes, I'm here. Can you hear me?
Hear you. Please carry on. Thank you.
Yes, I'm going to share my screen just very briefly if I can. It's not actually letting me share my screen, so thank you. I was just going to give an update on what the Trust are doing in response to suicide prevention. Can we have the next slide, please? Can you see the slides?
Not yet. We're just getting.
Okay.
Now we can.
Yes, next slide, please. Thank you. So within the Trust, we have our own suicide prevention strategy, but we work very closely with the other groups that Stephen's already mentioned, particularly the Thames Valley Suicide Prevention Strategy. We have a number of areas in focus. It's already been mentioned, the importance of moving away from the low, medium, high risk terminology and focusing instead on trying to create individualised risk and safety plans for people who use the services. We've got a big focus on safe wards and using data and patient and family feedback to really inform what it is we're focusing on. One of the things that's come up in the data for us is that we're noticing an increase in people with neurodiversity using our services and needing our help. So really important that we adapt our safety plans so that they meet the needs. We're focusing much more on inclusion, trying really hard not to have blanket exclusions, particularly for things like substance misuse. That was something we were seeing happening, so we've done a lot of work to avoid that. We're also focusing on our staff support and well-being, recognising the impact of a death, of a suicide death in particular, on our staff, and making sure we've got really good support in place, and supporting those people. It's been mentioned already, the economic pressures. You will have probably seen the 2023 ONS report that was published on World Suicide Prevention Day, really highlighting the economic pressures and the recent increase in suicide and the links there. Next slide, please. We have a number of research and conference events. One in particular that I wanted to flag that's coming up. The date in the slides there is incorrect. It should be the 29th of September. So that's this Sunday coming. And that's the Every Little Thing Festival. Berkshire Healthcare have collaborated with a bereaved carer to bring the festival, which will take place at the Novotel in Reading, and it brings all sectors together with service users and carers to focus on suicide prevention and shared learning. We have regular events within the Trust, webinars every quarter. We had a very successful one with Professor Louis Appleby in July. Our next one that's coming up in February will focus on neurodiversity, but also mental capacity. And we'd really like colleagues from across the system to be able to come and share those webinars and share the learning. Another initiative we've been involved in is Life Beyond the Cubicle. And this is something we've piloted with carers and Oxford Health. It's an online resource. It complements our 5-day training, which is face-to-face. And we also have a number of short 1-day trainings and hour-long trainings that we want to try and open those out across the system to get more people learning together. That there's some international research going on to look at staff competencies in suicide risk assessment as well. So quite a lot of work going on within the Trust. Another thing I wanted to flag, it's not on the slide, but we've just launched a carer panel whereby if carers have a concern about somebody that might be feeling suicidal, and they feel that the care team that's looking after them, that there's issues that can't be resolved, they can come and talk to an independent panel that can then think together with the carer, with the family, to bring about resolutions and improvements. And we've developed that because of feedback that we've had from our serious incidents where families haven't felt heard or haven't felt listened to by the Trust. So that's just an update from the Trust side of things. Thank you.
Thank you very much for that, Susan. I'm just noting that the support for those who've been bereaved by suicide seems to be very high, I think, in both the reports. And is that because, is there a danger that relatives and supporters can also become suicidal? Is that just sort of something quite recent that you become aware about, that they need specific support from suicide, that it's not just ordinary bereavement support doesn't fit the bill? Is that something that's evidence has come forward through surveys or through just constant feedback? Anybody want to comment on that? Susan? Yeah.
Yes, that's right. Oh, sorry, Stephen, did you want to come in?
Please go ahead.
Yes, that's right. Someone who's bereaved by suicide is at increased risk of suicide themselves. And you're right, the bereavement support in general needs to be tailored for those who've had, you know, a traumatic death like a suicide. So it is different support that's offered. So really important that we've got organisations like Amparo being able to help us with that. And of course, if people need other types of support when they've had a bereavement, then the Trust will provide the usual mental health supports alongside whatever else Amparo are offering.
Thank you. That's good. It's good, and it's good to hear that your quick reaction to what you were hearing from your own staff and from carers. You know that you needed other ways of addressing things. It's good that that's responded to. Stephen, did you want to add anything?
I was probably going to say more or less the same thing as Sue, but I guess the other key part about responding to bereavement by suicide, for bereavements around suicide, is the importance of rapidly making contact with those family members and relatives, which is facilitated through referrals from the police and through the real-time suicide surveillance systems that we have in place.
Yeah, I suppose there's this overwhelming guilt, isn't there, really, that they should have done something is probably. There was, there's some, I don't know where that's coming from. One of the figures in, I think it's in your report, Stephen, on page 57, figure 3, where there's a sudden rise in West Berkshire in, was it hospital admissions for self-harm? What was that about? 2014 or 15 or something, and suddenly the figures shot up? Does anybody know what happened, why that was the case? Why West Berkshire?
I do not know, I wouldn't want to speculate immediately. I'm happy to look into that, but if anyone else has any thoughts.
Because there's been a general discussion, and you know, for a while about West Berkshire and self-harm, and particularly young people, and and self-harm is a precursor to suicide, as you say in your report. And I haven't heard anybody really say why West Berkshire and self-harm. Why is that high? Why? What's that all about?
Because we're talking about numbers which are of the order of 33 in 2 years or 3 years or whatever it is, it doesn't really take many people for that to happen. So it might not be a trend, it just might be circumstances. I'm wondering, that's all.
Just a sort of glitch and suddenly.
Yes.
Okay, and it just, because it's small numbers, it looks big on the graph.
Yes.
That is. So there's something rustling going on. I can see Matt's hand here, and I wonder who is causing this sort of background stuff around the microphone. So can you just check your microphones are off if you're not speaking? Thank you. Yes, Matt?
Yeah, thanks, Chair. I mean, when I was in Herefordshire, this is something we also had an issue with, and I'm not saying it was necessarily down to this in this case, but it can be down to coding as well within the hospital system. So it might be a recommendation of this board that we go away and do a bit of a deep dive into this data. And I don't know whether West Berkshire's done that before, but it could be a good opportunity to just maybe explore the data a little bit more and then come back to the scrutiny committee about what we find.
Thank you. That's very useful. I think Vicky's making a note of that. Thank you very much for that. Just looking around. I mean, at the end of certainly Stephen's report, you're looking for things that you think might have been missed, or action, what the action plan might include. I mean, I go back to parents again, and I think, I mean, there are initiatives out there. They're probably not particularly popular now. And there's probably not the personnel to do them, sort of helping parents, expectant parents and parents when they've had their children, right from the word go, to understand how important it is to listen to their children. I mean, a lot of parents don't have the time, sadly. And that's an issue, you know, about making the most of the time that you do have. And maybe there's too much emphasis about keeping your children in check and making sure they behave and all that sort of thing, particularly with boys. And you do notice the difference in attitude of parents to the boys and their girls. And boys are always being kept under check, sit still, behave yourself. I only know boys. I've got 3 boys and my grandchildren are all boys. So I like boys. And I think girls are terrifically awkward. But I think listening and talking and knowing how to, a long time ago when I was a health visitor, I did some training in sort of trying to help parents to active listen with their children. And it's amazing how beneficial they found it. But all that sort of stuff that health visitors did at one time no longer happens. I mean, you're lucky if you even see a health visitor now. So any personnel, anybody that's working with children and families, try and help them to realize that they're there to, get to know their children. They're not just disciplining them all the time. And I think that if you go through life learning that you talk about your feelings, particularly with boys, then you might carry that on into later life and you won't bottle it all up and you won't end up doing something dreadful, hopefully. So that's just something that I'd like to bear in mind. And also there's the business about managing future pandemics, which I already raised. And before I say anything else, Stephanie's got a hand.
Yes, I wonder if I might ask how the national campaign by the parent who lost his daughter to suicide, 14-year-old daughter to suicide, through the influence of websites and social media promoting suicide, has impacted our prevention strategy at all?
Thank you. No, that's a good question. And I don't believe, so I wasn't here in the development of the Berkshire-wide strategy. I don't believe that features strongly. So thank you for raising that. Online safety, media and technology is highlighted in the National Suicide Prevention Plan. So I think both that and your comment suggest that we, at least in West Berkshire, will want to look at that as we develop the West Berkshire Action Plan. And it has been highlighted as an issue in the from colleagues in the West Berkshire Suicide Prevention Action Group. And some of the suggestions around that is where we look at social media, supporting people to use social media and being aware of the dangers associated with that.
Thank you for that, Stephanie. Thank you. Oh, sorry, I'm not looking on the screen. Gary, yes.
Part of the prevention strategy, really, but when people do come in contact with clinical services, Sue and her team have done a lot of work in educating clinicians about asking questions, about searching online for suicide, or when people are thinking about suicide. So at that stage, we try and explore with people what it is that they do online and try to support them accordingly.
Thank you very much. Thanks for that, Gary. Thank you. I mean, one of the things that, Stephen, you said in your report is how can actions be communicated to raise local awareness? I don't know whether members have any comments there. I mean, again, I'd say, we need to use our parish councils, particularly getting out to rural areas, and all the councillors have links with the parish councils. And they do some good work in many ways. They're not just, a thorn in our side. They do good work. I think we should use them and communicate with them. And again, use the councillors, make sure we're all aware. And I'm sure we use, places, if you're talking about young people, places like Berkshire Youth, getting information out to Berkshire Youth. I don't know whether members have any other thoughts. Oh, Jane.
Thank you, Chair. I wonder if I could say something that's very old-fashioned and probably not acceptable. So I apologise in advance. But when I grew up, I had to go with my parents to church every Sunday. And church is an amazing mental health helper, because you go, you're in a community, you're with your parents, you're talking to your parents on the way there and back, you're talking to other people, other children. There's music, you sing, You listen to views and thoughts, sometimes about expressing feelings. Unfortunately, the intelligentsia of the last decade, last century, really rather poo-pooed the attendance of church. But, you know, to go once a week to an organisation like that, I used to think that when I was growing up, that was a great mental health assistant. And I'm not just talking necessarily now about the Anglican Church, all churches of all denominations, including not, if you like, Western denominations. But these are facilities and networks. There's a huge network of these organisations around and in rural areas. And none of our speakers today mentioned using them.
Thank you very much, Jane. That's interesting. I think churches sort of certainly informally are involved in various groups. I think that and certainly the initiative, the Warm Spaces Initiative, which is meant to help particularly older people. I mean, it came up, you know, because of obviously sort of cost of living, but it actually is a way of combating loneliness as well. And there are lots of initiatives which are often hosted by the churches. So I think there is a recognition, but I think it's an important point you make. And certainly, I mean, we're all different. Some people have negative experience of church. Certainly, my church at the moment is somewhere that I value, and I love singing, and so I love singing the hymns. But yeah, so I think it's an important point you make. And if we're not working with churches and recognise them as partners more, I think we probably should. Because some of them are very valuable and they want to be involved and they want to help most of the time. So hopefully we'll make sure we take that on board. And maybe any information that we have about anything should be going out to our churches. Our churches, all these warm spaces where people are going to be meeting over the winter. Yes?
I'm just one point, really. The intelligentsia, if you like, of the last century destroyed a lot of churches and people going to church and didn't actually put anything in its place. And that's what we're all struggling with now. That's what we've been struggling with, listening, that we're all struggling with around this table today.
It's just community, isn't it? It's sort of feeling a sense of community. And sadly, in rural areas where people tend to think, oh, you've got these cozy communities, is probably less the case, isn't it? Probably, Nick, would you say? Rural areas suffer through being isolated and maybe need more places to gather, you know, or more people to initiate a community. And COVID did do something for that. It brought communities together and some of those have carried on. Anybody want to comment anything on that? Do you have anything to comment, Nick, about communities? Stephanie does.
Yes.
It varies. Sorry. I guess it varies depending on the village in question. Our particular ones have got a fair amount of active community groups, but it's more maybe the link with the services. I guess it's my concern, the practicality of people in a village getting access to the relevant service. As was discussed earlier, though, it's been kind of covered. We have to go potentially to say West Berks Community Hospital, for example. For not everyone can get there that easily. That's probably the issue for us. Yeah.
Stephanie.
Yes, in the report, paragraph 6.2, it does ask us as a committee to support the suicide prevention action plan, but it does say in paragraph A or sentence A, are there local priority areas or groups that the action plan should include? And that's where Jane's can be taken on board, that the groups that should be included are all the churches and all faiths. And in fact, when we have churches together. So there are lots of groups that can be accessed.
Thank you, Stephanie. And when I mentioned parents, I was thinking of them as a specific group that we're not making enough emphasis on.
Can I just add?
Yes, Jane.
Thank you, Chairman. I mean, I'm sure the churches will be happy to display, even if we can't display these in the foyer here, reception area, churches would probably be very happy to have these flyers. Thank you.
Yes, that's a good point. But yeah, but the people who aren't accessing churches probably maybe need them more from what you just said. But certainly they're a way of getting information out to people. Has anybody got, so we have, hopefully we've added some useful comments for Stephen and for Susan there to take forward. And again, if we think of anything after this meeting, because there's a lot to digest in all of these reports, which are very informative and, take a lot of time to put together. If we think of anything after the meeting, we can communicate that to the presenters. And thank you all for your presentations. They've been very thought-provoking and very useful. So thank you very much to everybody. Are we happy to move on now, I think, to our next item, which is item 8, where Helen Clark. Now, have members got the winter? Did anybody? Should have that. So hopefully you had an additional paper on the winter plan. HOSC, in fact, is us. So in case because I was wondering what it was. It's scrutiny. So it's just a way of talking about health scrutiny. So this is us. It's not some other organisation. This is a report that we requested from Helen. So I'll hand over to Helen. Thank you.
Thank you, Chair. So this is just 2 areas that we were asked to provide updates on to the HOSC. Apologies for the use of the abbreviation, but yes, the Health Overview and Scrutiny Committee. The winter planning update is quite brief at this stage. At the time that I wrote this update, we were still awaiting the national planning letter, although we had a sort of fair idea what would be in it. That letter was released last week. I don't think there were any surprises in terms of its content, so focusing on the areas that we've highlighted in the paper and providing more detail around some of the sort of system control arrangements that will support those. With regard to our place-based plan, so we will be developing a winter plan for Berkshire West with partners, so the trusts and the local authorities as well as other partners with whom we work. That will be part of the BOB winter plan, so Berkshire West, Buckinghamshire, Oxfordshire, Integrated Care Board will produce one plan which the local plans will form part of. Our Urgent and Emergency Care Programme Board met last week and considered a draft of the plan. We then have a BOB-wide planning session in October and then a further meeting of our Urgent and Emergency Care Programme Board on the 17th of October. So at that point, we will have a signed-off plan, and I'm happy to provide further information or some further discussion around that if that would be helpful. So a bit of a sort of question mark over the timing in terms of the level of detail that we're able to provide today. So that was probably all I wanted to say on that point. We're very much in the preparatory phase. One particular focus at the moment, as you would imagine, is on winter vaccines with the vaccination programmes for flu, for COVID and for RSV, the respiratory virus, starting up now. So that's a particular focus alongside doing the more detailed winter planning, which, as I've said, we can provide a further update on in due course. So shall I pause there, Chair, because there are 2 sort of separate parts to this update, the first of which was the winter plan.
Okay, what you'd like us to comment on the winter plan before you move?
If there's any particular comments and questions. I mean, as I say, it is just a sort of work in progress update at the moment. And if we have more detailed questions, it may be that we need to consider those at a future meeting.
I assume we're talking about the winter, and we used to talk a lot about the danger of falls and things during the winter and preparation for those and how we could prevent them. I mean, I suppose our winters are getting milder, although there's a lot of rain around. I assume we're working with public health in falls prevention and on all those. I assume that work still goes on, because obviously, keeping patients healthy, etc., is important. You mentioned vaccines. Is the uptake still good, or is that tailing off a little bit? Are people still keen and taking up on vaccines?
So we're very much at the early stages of the vaccination programme at the moment. So I probably wouldn't want to give too much information around uptake, because I think that data is still coming through. but previous campaigns and phases of the campaigns, particularly the COVID vaccinations, have been in line with national figures uptake wise. But yeah, again, happy to provide a further update once more information becomes available. With regards to falls, yes, absolutely. So a whole stream of the winter planning and the urgent and emergency care programmes board's work relates to admissions avoidance, of which falls is a key element. You may be aware it also forms part of the Better Care Fund planning, and as such falls has been identified as one of the priorities for the West Berkshire Locality Integration Board, and we're working as an ICB closely as part of that board to support that work stream. So yeah, falls prevention very much a key priority in this area.
And you mentioned reducing inappropriate out-of-area mental health placements. Is that does that happen quite frequently? Is that to do with there being no space in our local hospital?
So probably a question from some of the colleagues that have joined earlier, but yes, that remains a concern both locally and nationally with regards to placements being made out of area where there may be local alternatives. I think in this context, the particular concern is also around the timeliness of placements and as part of the work to support discharge, ensuring that the patients aren't sort of inadvertently ending up within the acute setting for longer than is required. So really maintaining that flow into placements. But yes, it's probably an area that to discuss in more detail we would need to raise with mental health colleagues.
All right, thank you very much. Yes, all other presenters have left now. Okay, thank you. Would you like to go on to the comment?
Yeah, so the second area that I was asked to provide an update on was the additional roles reimbursement funding, which I think we've discussed previously in this committee, but just to remind members, is funding that is available to general practice as part of the element of their contract that relates to primary care networks. So essentially provides funding for the employment of a range of roles within primary care that perhaps traditionally weren't part of the practice team, but now are really sort of gaining traction and helping to address recruitment and retention issues and ensure the sustainability of services going forward. So within the 4 PCNs covering the West Berkshire area, there's around about £3.6 million of funding associated with the additional roles reimbursement scheme. It works out to, I think it says in the report, it's just under £23 per patient. We've now at the point that we have 95.74 whole-time equivalent members of staff working in the primary care networks funded through this route, a very slight reduction on last year, but I think that relates to sort of general turnover rather than being a particular trend. We've noted in the report that 3 of the 4 primary care networks spent their budget in its entirety. The 4th had a slight underspend, and I know the primary care team are working closely with that primary care network to understand that in a little bit more detail. Highlighted in the reports are the sorts of roles that we're talking about. So particularly high numbers of recruitment of care coordinators, clinical pharmacists, paramedics, pharmacy technicians, and also social prescribers. There are some roles it says yet to be filled. I think it's more that primary care networks haven't necessarily chosen to focus on these roles initially, and that is in common with the rest of the patch. So so not unusual. Some of these are the newer roles that came into the scheme, so are taking some more time to establish. But we are working very closely, as we've highlighted already, around the mental health practitioners funded through this scheme and how they link with the broader mental health community teams that we've been describing. And then we've just included a bit of a chart showing the summary of the numbers of people in particular roles that we now have working within our primary care networks. I think there was also a question about feedback and engagement with patients around the experience, their experience of having contact with these new practitioners. So we are working with our primary care networks to develop and build that feedback. We haven't got any sort of firm data to share on it, but it is an ongoing conversation and was picked up also through our primary care strategy engagement. You'll recall we did quite a lot of work around the development of the Bob ICB primary care strategy, which included a whole focus around workforce. And I'm also aware that Healthwatch, we've got Jamie on the call, Healthwatch have recently undertaken a piece of work around GP access, which also considers how we support and engage patients to understand the place of these roles within primary care and how they fit within the wider primary care team and interface with the GPs and the more sort of traditional staff members. So we're really looking forward to working further with Healthwatch in response to that report and to agree further actions following it. So yeah, that's probably all I had to say at this point, but happy to take any questions.
Oh, thank you for that, Helen. Yes, I mean, it's interesting to see about the overspend. Obviously, they need these practitioners. They're really helping the GPs to fulfill their roles, aren't they, and to concentrate on what they can do. And, and they're being asked to sort of expand and to sort of delegate things. I mean, the social prescribing, what's that saying? Average per primary care, 1.75. Does that seem 2 practitioners per surgery? Is that per?
So that's per primary care network. So I probably should have said, I think one of the features of this funding, which is sort of different to the historical employment model, is there is capacity for primary, is at a primary care network level, which means that, which means that there is a ability to recruit staff across practices. So that's the reason that the figures are presented by primary care network rather than by individual practice.
Right. So a practice might not well have access to these, particularly the social prescribers. So there don't seem to be that many of them. So they might have to will they refer them to someone else? I mean, they won't just miss out on that facility because it's really important and it's being used a lot, hopefully now, isn't it? Particularly as regards supporting mental health. Yeah.
Yes. So it is a practice decision as to which of the staff they choose to appoint. But where you can see that there isn't necessarily one per practice, in many cases, those practitioners would be working across practices, or they may have somebody less than full time.
So they'll have a place where they can go meet them in one of the surgeries. Okay. Are there any members got any? Yes, Nick.
Yes, just on that general point, I know we had a discussion about this once before, I think. I mean, in one of my practices, I still think patients seem the sort of front door link into these supporting roles seems to be the GP based on the interface they have with the surgery. In other words, they ring up and the question is, do you need to see a doctor or don't you? So I'm still a bit unclear. I can understand how some of the roles you've described will be brought in, but I suppose I'm unclear, A, whether our particular surgery has access to them, and I guess that's an individual surgery question, and B, the idea that when somebody rings with a particular issue, they don't necessarily need to see the GP. We still seem to find that it's either that we have to see the GP for a lot of things, which is that how it should be, or should the triaging work differently, I guess is my question. Thank you.
Yeah, so I think we have touched on this point previously. So I'm happy to take back any questions with regard to individual practices, and I can pass those to our primary care team, who in turn will follow up with the practice if that's helpful. But I mean, there isn't any standard model for how these staff are used or for the exact triage pathway into practices. So practices will manage it slightly differently, which is one of the challenges when we're trying to communicate with members of the public about the new roles and how they work. But yeah, so there will be differences in the pathway depending on the exact skill mix of the practice and how they've chosen to use their staff and to operate the triage process. But yes, happy to take specific questions. If that's helpful, I would need to take those back to our primary care team.
Yeah, no, thank you very much. That is helpful. Thank you.
Thank you, Nick, and thank you, Helen, and thank you for your report. I can't see any more hands for questions, so thank you very much for joining us this morning. Thank you.
Thank you.
Bye-bye. Thank you. And now we have item 9, which is a Health Watch update. Fiona Warby can't be with us today, and we have Jamie Evans, Health Watch Area Director, with us. And I know, again, I don't think members don't have the Health Watch report. So, Jamie, I don't know, can it go on screen? And you can. So Vicky is now going to share it with you, so you can see it. I think it probably came through a little bit late. So just hang on a minute, Jamie, while Vicky gets it up. Okay, it's a bit small, but maybe you can see it. If you can go through it, Jamie, that would be useful. So these are the projects that the work plan that Health Watch is working on at the moment, and Jamie is the area director, so he's probably not as hands-on as Fiona would be, but hopefully you know a bit about these projects, Jamie.
Yes, yeah, I know plenty about the projects. So the work plan for each area is set at the start of the financial year. So we're roughly about 6 months through that at the moment. There are different ways in which the projects are delivered. So some of them are done through workshops, some of them are done through surveys, some of them are done through other data collection methods. So Pharmacy First started early this year. We are running a survey later this year from around December until February, and then that will be collated into a report about people's experience of the Pharmacy First process. The maternity project that the team delivered was completed earlier this financial year, and that's now being taken up by Maternity Voices at 4 hospitals who wanted to expand it further and link in together in their approach around it. The youth project that Fiona and her team have been running is just about to come to a close. So that's a RAC card that's going to go out with relevant information for young people about their rights once they turn 16 and the types of services that they can offer. So that is getting signed off at the moment in terms of it being an appropriate document, and then that will go out in the next couple of months or so. So a bit further down from that, we've got the GRT project. So that is a partnership project with Solutions for Health, which is a little bit on hold at the moment. But that is about speaking to the Berkshire community and learning about their experiences of accessing health services and what they know about it. And then the unpaid carers are taking in some case studies across the financial year to look at people's experience of their own health needs and the type of support that they might be able to access. The team have also taken on a recent project around Slavic and Eastern European communities, and that's specifically around feedback that we gathered from predominantly at this stage from the Polish community. That they are going back to Poland to take advantage of the health services there, and that they don't use the NHS for surgery or for ongoing care or anything like that. So we're trying to understand the implications that that might have here in terms of the impact on the health service. And then following on from that, the Women's Health Hub was a project that all ICBs across the country were given some funding by NHS England to deliver. It was a 2-year project. We were into the 2nd year at this time. The short version is that there was nothing happening with it. We queried that, and this project has been resurrected in a sort of form for the last 6 months of this year. It is not really going to do much other than hopefully proof of concept that women's health needs to be treated in the round, and that if they have access to a service or a hub where they can go and speak about all of the health needs that intermingle in their lives, then there is a benefit there that spreads across various other areas. Fiona is also currently inquiring about the Bob ICB Continuing Healthcare Programme Board, which was due to start last year. We haven't had any further updates about that or been involved in that at any process, so we're trying to find out what is going on with that. There's information there about the monitoring, so the nature of the themes of complaints that we've received. And the compliments that we've received as well. And then at the end of the report there, we have the GP Access project. So that report is due to be published next Monday. We're waiting for one response from the ICB at the moment, and then that will be finalised. And then, as I mentioned, the pharmacy survey will be available out to the public in December for 2 months to February before we produce a report from that as well. So that is the update for Healthwatch.
Thank you very much, Jamie. When you say the report will be published, is that sort of online and is that open to the public? Is that public?
For the GP Access?
Yeah, the GP Access project you said was going to be published next month.
So that will be published next Monday, and that will be on our reports section on our website, and it will be published and promoted across social media, so it'll be accessible to anybody who wants to see it.
I suppose people need to be encouraged to look at the Healthwatch website. Yeah, there's a lot of interesting projects there, and hopefully we'll be hearing more about them in the future. The Women's Health Hub. So again, that's all online. I'm not quite sure how that works. So it's really just people sort of talk to each other online, or how does that work?
No, that won't be online. That will be at a couple of surgeries. It was meant to be across the Berkshire West area. It's an in-person hub. That is the purpose of it. But it's actually going to be at 2 surgeries. And it's not going to have the scope that it was originally planned to have.
How would that work? How will Healthwatch cope with that? Because I mean, there's very few members of staff. I mean, are they meant to get this hub going, or do they just facilitate some?
RBFT, who are the partner who are running the hub or establishing the hub from October, they have asked us to be the public consultation on it. So we will be opening out a survey, and we will be contactable for people who have attended the hub and encouraged to contact us to share their experiences of what worked, what didn't work. And that is the way that it will generally be done.
I was going to ask Fiona if she was here, but I mean, I know, they're a very small staff and they're sort of limited with their time, but Healthwatch used to do interim view to homes, hospitals, services, and I don't think there's any members trained to do that at the moment. And I wonder if that is something on the agenda going forward to train members and to look into doing interim view in the future.
Yeah, so as area director of Berkshire West, I'm trying to drive the strategy forward for the 3 areas. And as part of that, what we are looking at is an interim view volunteer recruitment campaign that will be coming out. And that will be specifically, it's not just interim view volunteers, it is volunteers in general. The teams across the 3 areas are very, very small and have very limited capacity. So we're looking at ways to support that around volunteering. So interim view will be specifically recruiting people to be trained up and to do interim views so that we can have a regular program of them, rather than the feeling for the staff at the moment, which is that they just don't have the capacity to be able to deliver interim view.
Yes, I mean, people need to be trained to do this, so it's quite an undertaking. Members of the board and volunteers. Yes, I think the number of volunteers has sort of disappeared over the last few years.
We have 2 at the moment, and one of those volunteers is happy to do research on our behalf, but doesn't want to do any kind of public engagement. So, yeah, we are quite limited. I say 2 volunteers; they are outside of our volunteer advisory board members, which we have 5 at the moment.
Okay. Oh, that's good. That's good to hear, and it's good to hear of the future plans. Have members got any questions? Or yes, Stephanie?
Yes, please. Forgive my ignorance. Can you just tell me how you follow up on the complaints, please?
So the complaints for us is usually we have a signposting procedure. So we will signpost the people making the complaints to the effective way to register their complaints. So for example, if somebody was to complain about their GP surgery, we would share the process with them that if they're able to, they complain to their GP surgery through their complaints process. If they're not, then they can go to NHS England. So we talk them through whichever the process is for registering a complaint.
Thank you very much.
Any more questions? Right. Thank you very much, Jamie. I think that that is all the questions for now. Thank you very much for coming here today. Thank you very much.
Thank you. I will have to leave now, but if there is anything else that anybody wants to know, Fiona or I will be happy to get back to you.
Thank you very much. Thank you. I'm sure we'll do that. Thank you very much. Bye-bye then. Thank you. Bye-bye. Item 10 now we move on to is the terms of reference for the new task group that we're proposing on children's mental health and emotional well-being. And members will remember that the concern about waiting lists and services for children's mental health and the importance of addressing mental health issues in early life so they don't become chronic was sort of recognised. And because we were finding that the answers to these and looking into the service needed a little bit more time than we could give it by just calling practitioners to a meeting such as this, we decided to have our own sort of task group. So you'd have seen the terms of reference, which hopefully you're all happy with. And so any comments or questions, happy to take them in. But what we really need today is we need people to volunteer to be on that task group. And it gives you an idea what we'll be considering. It's a limited time. It'll have so many sessions, so it's not going to go on forever. And as well as ourselves, we can also invite other counsellors, not on this group, whom we think would be interested or would have some, maybe some expertise even, but definitely an interest to actually join us. So you can volunteer now, or you can volunteer after the meeting. So I'm volunteering. Stephanie's volunteering. Owen's volunteering. Did your hand go up, Nick? No. Oh, you just scratched your head. That was dangerous. So you've got anybody else? So we got, okay. So if we need 5, that would mean we get 2 more members from the wider council, which would be good because we get some fresh ideas coming in. I've got my own thoughts, but you might have, from knowing your colleagues, you might have your own thoughts about who you think would be useful to join us. So thank you very much for that. And we look forward to getting on with that. Okay. Okay, Vicky, you don't need me. So next we move on to our work programme on page 99. So you can see what we'll be looking at. Yes, Stephanie.
Sorry, Chairman, I'm sorry that I'm not available to visit Eastfield House Surgery. That's the top one. And I can't come on that visit. But can you explain to me why this committee is doing that visit, please?
Well, we thought we weren't very happy with the consultation process that they went through, and they didn't actually approach us as Health Scrutiny, and they probably didn't know that they should. So it was really the fact that, so this is our sort of little scrutiny process, isn't it? Or they are coming to Health Scrutiny a meeting afterwards as well, aren't they? As well as a visit. Then we have, are they then coming to a future meeting, or is that?
Yes, so one of the main remits of the Health Scrutiny Committee is to be consulted on substantial variations of service. So Eastfield House Surgery relocating would come under that. So it's on the work programme for the December Health Scrutiny Committee, but as part of that pre-consultation, Eastfield House Surgery have invited members to go and see what challenges there are and what their proposals are in their relocation.
Do you think there would be any facility for Stephanie to pop in, or would that be a difficult if she can't go that time?
As long as you tell.
Huh?
If you report back,
Okay, you'd be happy with that, will you? Okay, yeah. Okay, that's good. So yeah, it'd be very useful to visit. I mean, I did go to the consultation they had in the Richard rooms, where they were consulting with their patients. But as Vicky said, it's the process. So they really didn't know that they should do that. Was that the case?
Yes, they weren't aware that it can be done now.
Maybe we need to make the surgeries or the, I don't know, ICB or somebody aware that they should make sure they know that this is the process.
Yeah.
Helen's nodding.
Yeah,
Do you want to comment, Helen?
Yeah, no, only to say, Vicky, I think it might just be helpful for us to have a conversation offline, if that's okay, just so we can be clear that the due process is being followed on this one.
Thank you, Helen. That would be useful. Thank you. So any other comments on the work programme? Any thoughts? And we've got health in all policies. Have we got that somewhere along the line? Because that's something that we said we would look at. It's mentioned in the reports, and it's something we're very aware of. You know, that we need to be including health in all policies. I think that was going to be a future item.
It is on the work programme at the moment. The advice I've been given is that now's not quite the right time in terms of resources, but it is going to be looked at and just needs to be scheduled.
Thank you, Vicky. And oh, Helen's got her hand up. Yes?
Yeah, I just wanted to ask a question around the ICB update, which I note is a standing item. And again, Vicky, happy to pick this up separately if that's more appropriate. I'm just conscious, so this time our update, we only included the 2 items that HOSC had specifically asked, or that the committee had specifically asked us to cover. We do a more general update for health and wellbeing boards. However, which, you know, we could share, but I'm conscious we wouldn't necessarily always have the right person on the meeting to be able to answer detailed questions in a general update. So I wonder, Vicky, whether we just need to have just a bit of a conversation about what the purpose of that standing item is and how we make sure that it's useful for all parties.
Thank you very much, Helen. Yes, that would be useful. So that's something else to talk about. Thank you very much indeed. Thank you.
Thank you.
I mean, another item that we hope to put on future work programme is, again, because it's such a concern, is childhood obesity. So that's something that we'll be looking at some stage in the future. Okay. And obviously, if anything else comes to mind, Jane.
Thank you, Chair. I wonder if it's appropriate for us to be scrutinising how the GP access goes and any feedback we might need to make them aware of. Should that be on the health on the list?
We've got GP access, GP provision.
Have we got that? I'm sorry, I've my
access to primary care is coming up in December.
Oh, okay. If that comes under that, that's fine.
Yeah, because that's obviously a still concern. Is that okay?
Yeah, that's fine. Thank you. Okay. Sorry.
So yes, so this is live. If anything comes up that you think isn't being addressed, then we can make sure we'll include it in future work programmes, because we want these to be the issues that you are hearing or of concern or you're concerned about yourself. So it's not all set in stone. You must come forward with your own thoughts and ideas, and then we'll think about them. Thank you very much. Okay, any more comments on that? No? Okay, everybody happy? Right, okay, so sorry we've gone a bit over time, but I think that's all the business that we have on our agenda. And thank you very much for everybody for participating and for your questions and for our officers that are here. And thank you very much. So good morning, enjoy the rest of your day. Thank you.